Best people in ENT radiology today. Okay, so please give her a warm welcome. Can we have the lights dim down a bit tak? Nanti tak nampak. Oh, okay. Oh, you jangan tidur
Everybody keeps on saying that, and they like want us to tidur. They found it. I wonder, you got extra.
Oh, there.
Oh no, I got.
Alright.
Which one? Also, sweets. Minta orang ni siap-siap.
Alright.
Langsung.
Okay, a very good afternoon. Assalamualaikum and a very good afternoon to all. Thank you very much to the organising committee for inviting me today. What I'm going to do today is to share with you some the aspect of imaging in paranasal sinus. You're going to see a lot of black and white, a lot of CTs, and not so much of MR. Because when we deal with paranasal sinus that contains a lot of air, usually the best imaging modality would probably be CT scan. Okay.
Next. Dah mengantuk.
Oh, I have to do it. Okay. Alright, so I can just do it. Okay. Alright, okay. Right. So this is going to be the outline of my talk. I'm just going to touch a bit on the anatomy and discuss with you which modality to use, especially to look at certain structures in the paranasal sinuses, and characterization of the lesion using CT and MR, and in between, I would slot in some case illustration for you to be able to consolidate whatever that I'm telling you. Right, so just an overview of the sinonasal cavity. The cavity is actually a triangular shaped structure with a septum in between. The roof is formed by the cribriform plate, and the floor is formed by the hard and soft palate, and the lateral wall is formed by the lateral nasal wall. And the bony septum has actually got two components, the bony septum and the cartilage. And the turbinates, three of them, they are all attached to the lateral wall of the nasal cavity. And there are three meatus, the superior, middle and inferior meatus. This is where all the paranasal sinuses drain their secretion into. So this is an overview of the CT scan done in coronal plane. And here you can see the different sinuses which can be visualized. The best plane to look for paranasal sinus, looking at the osteometal unit or the osteometal complex, would be the coronal view. And here you can see the frontal sinus, the ethmoid sinus, maxillary sinus, and the OMU itself here. And these arrows basically showing you the drainage pathway of all the secretions that are coming from the individual sinuses. The red one is the drainage pathway for the frontal sinus, and they will all drain into the middle meatus. What about the ethmoid sinus? The anterior ethmoid sinus drains into the ethmoidal bulla, into the hiatus semis lunaris, then into the middle meatus. The maxillary sinus will drain into the middle meatus via the ostium, infundibulum, and it has got its own passage through the osteometal complex. What about the posterior ethmoid? They drain into the superior meatus, and the sphenoid sinus drains into the sphenoethmoidal recess, which then drains into the superior meatus. Okay. Now, the frontal sinus, I'm going to talk about the frontal sinus first. It's a paired structure, paired A cells located in the frontal bone itself, right? And it drains into the frontal sinus ostium, into the superior compartment of the frontal sinus drainage, which contains two. One is the superior and one is the inferior. The inferior compartment is a bit unique because it depends on where the uncinate process attaches to. The drainage will differ, but all will eventually drain into the middle meatus. Right, this is the coronal view. Again, showing you where the structures are. The frontal sinus, and that would be the passageway, the frontal sinus drainage pathway, and eventually will drain into the middle meatus. Okay. Okay, now I'm going to talk about the inferior compartment pathway. Depending on where the uncinate process attaches to, if the uncinate process is attached to the base of skull or the cribriform plate or the middle turbinate, then the frontal sinus secretion will drain into the ethmoidal bullae, hiatus semilunaris, then into the middle meatus. In contrast to, if the uncinate process is attaches itself to the lamina papyracea, or then here you will see that there is direct drainage of the frontal sinus into the middle meatus. Okay. Now, next would be the maxillary sinus. Okay, it's again a paired air cells in the maxillary bone, and here it drains into the middle meatus via the ostia into the infundibulum, hiatus semilunaris, then into the middle meatus. So this forms the osteomeatal complex. Okay, ethmoid sinus. Ethmoid sinus contains about 3 to 18 A cells in general, and it is quite important because it has got various structures within the confine of the ethmoid sinuses. One in particular would be the anterior ethmoidal artery, which is best seen here on the superior, on axial scan. On the superior aspect, you can see two notches here. The one anteriorly is at the level of the crista galli, and here you can see the notch here, where the anterior ethmoidal artery traverses. And posteriorly, another notch is seen, and this is where the posterior ethmoidal artery courses to. And here you can see that the ethmoid A cells are divided into two, the anterior and the posterior, and they are all divided by the basal lamella. It is where the middle turbinate attaches to the lamina papyracea, defines where the basal lamella is, and it divides the ethmoid A cells into an anterior compartment or posterior compartment. Okay, so you can see here that would be the anterior ethmoid, posterior ethmoid. And here you can see that posterior ethmoid is in close proximity to the sphenoid sinus. That would be the anterior ethmoid. And this is a normal variant, Agarnici cell. Right. I touch on the anterior ethmoidal notch. This can be visualized on the coronal even better. Here you can see that there is a notch here at the superolateral aspect of the ethmoid sinus. So when the notch is in contact with the fovea ethmoidalis, this is considered safe. The anterior ethmoidal artery is considered protected. But in some circumstances, when you have pneumatization of the supraorbital ridge, you can obviously see here that the notch is bounded by air-filled cavity and superiorly and inferiorly. So this particular variant will impose surgical risk in cases of FAS. Another thing that one would have to look for would be the integrity of the lamina papyracea. Okay, on coronal view here you can see there was a lamina papyracea fracture and with dehiscent, and there is herniation of the orbital content into the nasal cavity. Another important cells which is of normal variant would be the Ono D cells. Okay, this coronal, I like coronal, so coronal is best to look for Ono D cells. And here you can see that it traverses superior to the sphenoid A cells, and within it, what is important is this structure here, which is the optic canal, right? And you can see that the optic canal protrudes into the Ono D cells. So this variant increased risk of surgical injury. Okay. Next would be ethmoidal bullae. This is a dominant anterior ethmoid A cells, and you can see that it protrudes infero-medially into the infundibulum or hiatus semilunaris. This is important because it will cause obstruction to the OMU, osteomeatal complex, and would then lead to various complications. And here another example of an enlarged ethmoidal bullae. And look at the osteomeatal complex, everything is being pushed down. Okay. Sphenoid sinus anatomy and drainage. Okay, sphenoid sinus has variable configuration. It has variable pneumatization, septal insertion as well, and it has a very important structures around the vicinity of the sphenoid sinus itself. It drains into the sphenoethmoidal recess via the sphenoid ostium, which is best seen here on the exhibit, right? Okay. And this is how it looks like on the coronal scan. So what are the important structures that one would have to look for? First would be the optic canal here. This is the sphenoid sinus, and these two structures in the greater wing of the sphenoid bone. You can see here foramen rotundum and Vidian canal. Foramen rotundum is where the maxillary branch of the trigeminal nerve passes through. This is where the Vidian vessels and nerves would pass through. Okay. Pneumatization of the sphenoid sinus is important, especially for transsphenoidal surgery. There are actually three classifications. One would be the concha type, where the pneumatization is before the sella. The second one is the pre-sella, where it extends a little bit into the sella, and the post-sella. And this is the one which is you have to be cautious about, because if it extends posteriorly, it will cause thinning of the posterior clival wall. Another example of pneumatization, it can get very excessive at times. One here would be, this is the anterior clinoid process, anterior clinoid process, and you can see extension of the pneumatization into the anterior clinoid process. Again, leading to vulnerability to the optic canal here. Posteriorly, if there is extensive pneumatization, you can see protrusion of the ICA canal into the sphenoid sinus itself. Sometimes the bone is present, sometimes it is not, as seen here, where you see that there is dehiscence of the carotid canal. Okay. Another example of extensive pneumatization into both anterior clinoid process, rendering vulnerability to the optic canal and the ICA. Lateral pneumatization, which renders vulnerability to the foramen rotundum, and here would be the Vidian canal. Another example here, where you can see protrusion of the foramen rotundum, and even here, it's hanging and jutting in to the sphenoid sinus. The turbinates. The important turbinates and its normal variation would be concavulusa and paradoxical curve. Both will cause destruction and alteration to the drainage pathway of the secretions from the sinuses, especially if it obstructs the osteomeatal complex. So this is paradoxical turbinate. You can see that the curve is going inwards rather than outwards, as one would usually see. And concavulusa, this is quite common as well. You won't be able to see this on scope, but it's only can be seen on CT scan. You can see aeration of the concavulusa, and if the wall is inflamed here, you can see how narrow it is. It will cause obstruction to the osteomeatal complex. And some important cells, Haller cells, right? Haller cells. This is infraorbital ethmoid cells. Again, when it is large, it will narrow the infundibulum and would obstruct the maxillary sinus ostium. Agonistic cell, most anterior ethmoid cells and prominent here and here. And what it does, if it is large, it can impinge and distort the frontal recess and will cause problem to passage pathway of secretions from the frontal sinus. Onodi cells. Okay. I think I've explained to you earlier, this most posterior ethmoid cells that traverses superior to the sphenoid sinus. And here you can see the optic canal here, which protrudes into the Onodi cells. Okay. So the OMU, it is a very complex structure because various sinuses drains through it. The superior, the frontal sinus drains into the middle meatus and will converge into the middle meatus via a structure within the osteomeatal complex here itself. So what does it consist of? This is the maxillary ostium, infundibulum, hiatus semilunaris, and the middle meatus. Okay. Now, imaging strategies. What do we do? Most commonly used would be plain radiograph, CT, and MRI. Plain radiograph has a very limited use. For looking for paranasal sinusitis, sometimes we do them, but mostly it's done for fracture purposes. Computed tomography, on the other hand, is used mainly for looking for inflammatory disease. It is very good to exquisitely delineate bone or septation, which we can't see on MRI. But what about MRI? MRI is good to differentiate between a complex sinonasal disease, between secretions and a mass, which CT cannot do. PET-CT, ideally it's done. Basically, sometimes in MRI, especially post-surgery, we won't be able to differentiate if there is tumor recurrence. So hence why PET-CT is the modality to use to differentiate whether there's recurrence or post-op changes. Again, this is just a list of things that we do. Basically to look for, if you're going to look for sinuses, OMU, then CT would be the modality of choice. Bone abnormality, CT. Deeper, complicated cases, looking for soft tissue detail, MRI. Tumor spread, perineural spread, these are all would be better seen on MRI. Okay, now, computed tomography, plain CT. You know, for paranasal sinus, sometimes when you see CT, we see a dense structure on CT. If it is plain CT and it is dense, it is almost always a benign lesion. Tumor do not present with hyperdensity on plain CT. And what are these dense structure is caused by inspissated secretion, fungus or blood. Okay. CT, the drawback of CT. If you look at these two cases, this is a retention cyst and this is a mucosal polyps. If we do bone setting on a CT scan, especially for fast surgery, we usually would do it on a bone setting. We won't be able to tell you what this structure is. So the best thing to differentiate these two would be doing MRI. Okay, MRI basically is done to look for complicated sinonasal disease. We can differentiate secretion from mass, invasion of skull base, or perineural spread. But the content of the secretion vary according to the protein content. Note here that if the content goes beyond 28% protein content, the signal will be low on T1 and low on T2. This will cause pseudo-aeration in fungal infection. So if you do MRI as your first line of treatment looking for fungal infection, you may see a normal paranasal sinuses. But you have to complement this investigation with a CT, because only CT will be able to see if there is any opacification of these sinuses. Okay. This is looking for complex sinonasal disease. If looking from the T1, you know that these two things are different. The one within the maxillary sinus and the ethmoid sinus has high signal intensity on T1. So which means that it can be due to high protein content. And the one within the nasal cavity is hypointense on T1. And with contrast, you can see enhancement of the nasal cavity lesion, and the signal intensity on the maxillary sinus and the ethmoid sinus remains, right? It does not show. So we know that there is actually a mass within the nasal cavity which is obstructing the pathway of secretion from the maxillary sinus and ethmoid sinus. If you are just going to do T1 post-gado, you won't be able to tell. So MRI, it's mandatory that we do a couple of sequences, and you cannot interpret any abnormality just by using one sequence. Okay. Now, looking for imaging of neoplastic lesion, best would still be endoscopy, because you will be able to see the lesion itself and you can guide biopsy. But what MRI and CT is good for is to look for extent of disease which can't be seen by endoscopic examination, especially intracranial extension. If you want to look for this, do MR, not CT. And again, looking for inspissated secretion versus neoplasm, MRI would be best. Okay. Okay, this is a case illustration, a 29-year-old male who is immunocompromised. He presents with headache, and MRI was done initially for this patient. And here, can you see, in the sphenoid sinus, one sinus is filled with high T2 signal intensity, so there's secretion within it. But on the left side here, you can see that it is hypointense on T2, and here, hypointense on T2. You may have thought that this would just be a normal aeration, but when we do CT, this is what you saw. Okay, you can see that there is fluid within, so we know that this is not a simple, it's not a normal sphenoid sinus, but a sinus which contains high protein content, most likely fungal infection. Fungal does this. It will appear hypo on T1 and hypo on T2. Okay, another case illustration. This is an ethmoid sinus. Look at how expanded the sinus is, and within it, this is a plain CT. A lot of hyperdense content. So we know that this is something which is benign, likely inflammatory, right? And then here you can see that there is dehiscence of the lamina papyracea. And the MRI, this is T1, and this is what T1 post contrast. Can you see that that there is pseudo aeration? You see hypointense T1 without enhancement, right? So this is fungal sinusitis. Okay, now the pathology. I'm going to touch a little bit on pathology. The things that we see most often that we encounter would be inflammation cases, tumor or trauma. Sinusitis, we do get requests to view sinusitis, but mainly to look for complication and extension. Typically, the cause is bacterial, and here is the air fluid level, which indicates that there is an acute sinusitis. And we do look for intraorbital complication as well. Okay, this is air fluid level. You have to see a straight border within the maxillary sinus, because the image, the patient is done on supine position, so everything will be layering. Okay, you can see this is air fluid level. And here, you can see posteriorly there is dehiscence of the wall, so there is now a complication that may have occurred, and it has gone into the infratemporal part. Okay. Chronic sinusitis. This is due to recurrent infection, various causes, fungus, allergy, or all sort of things. And here, what is the criteria, or what are the things that suggest that this is chronic infection? Will be total opacification and this thickening of the wall of the maxillary sinus compared to the contralateral side. Okay, another example here. This is a T1. This is a plain CT, hyperdense with hypodense outline. This is likely the mucosa, which is inflamed, and again hyperdense opacified structure in the sinus, most likely benign. It can either be inspissated secretion with or without fungal colonization. Okay, and here you can see the wall thickening. So this is something which is chronic. Another example, chronic sphenoid sinusitis. Again, the wall is thickened with a few areas of focal dehiscence, and that is the obstructed ostium. So, sinusitis complication, what we look for would be subperiosteal abscess. Like in this case, it is an abscess. You can see that on T2 weighted image, there is high signal intensity in the frontal sinus. And adjacent to it, you see another hyperintense signal with hypointense rim, with a lot of vasogenic edema in the brain parenchyma itself. And on contrast, enhanced MRI post-gadolinium, you can see a ring-enhancing lesion, actually, within the brain parenchyma and the frontal sinus itself. And this is a sequence that we use to diagnose abscess. This is very important when we see restricted diffusion in an abscess. When we see restricted diffusion, it means an abscess, and it is caused by bacterial infection. Non-pyogenic abscess will not cause restricted diffusion. So that one is a little bit complex, but for now, because most of the time sinusitis is caused by bacterial with complications, so this is an abscess. This is restricted diffusion, high on DWI, and it has to be low on ADC. Okay, now another complication, again, sinusitis, chronic. You can see that the mass has now extended into the orbital apex, into the intraorbital cavity, as well as the cavernous sinus. And there is cavernous sinus thrombosis. How do you tell whether there's cavernous sinus thrombosis? Is when there is a filling defect within the cavernous sinus itself. Compare left and the right and left. And here you can see, it's bulging out. So meaning, there's something within. Right. Something within, it can be due to thrombus or it can be due to CCF. In thrombus, you will see a filling defect. In CCF, which is carotid-cavernous fistula, you will not see a filling defect. So this is a sinusitis with complication, which is cavernous sinus thrombosis. Orbital cellulitis is another complication. 2 patients. This is, I think, a 63-year-old man with sarcoidosis. And here you can see that there is a ring enhancing lesion within an expanded nasolacrimal duct. And you can see that there is soft tissue enhancement within the post-septal area of the orbit with some ring non-enhancing area, which is an abscess. So this is a post-septal cellulitis. Another example, proptosis. Again, look at the frontal sinus. It's very thickened, chronic. This is something which is chronic. And you can see that there is some breach in the orbital wall, and you can see an abscess within the orbit itself. Okay. This is a 64-year-old male who initially presented to us with headache and bright loss of vision. Initially, he was treated with as anterior ischemic optic neuropathy secondary to giant cell arthritis, and he was started off on high-dose steroid. Then he develops multiple cranial nerve palsy, 3, 4, and 6. Whenever you see multiple cranial nerve palsy, always look at the orbital apex or the cavernous sinus. And true enough, here you can see that there is enhancement in the area of the orbital apex here. And look at the sphenoid sinus. Okay, it has some opacity within it, and there is dehiscence of the wall here at the posterior aspect. So this is an ethmoidal sinusitis. It's actually fungal sinusitis in this patient who is diabetic, complicated with orbital apex syndrome. Again, another example, sinusitis with cavernous sinus thrombosis. I think this one clearly shows you that there is a filling defect. Look at how engorged and how gemuk the cavernous sinus is. It's laterally expanding like that, and within it you can see some filling defect. Right? And this is the MRI. This is even further confirmed with thrombosis that goes through the superior ophthalmic vein. Okay. This is another patient that we had, a lady who was given diabetic, given steroid, and came with this complication. Look at all the sinuses, it's all thickened. This is a post-contrast T1 weighted image. You see cavernous sinus thrombosis, and there is a leptomeningeal spread of the infection. Okay, sinusitis with subperiosteal abscess. Again, opacified ethmoid sinus, and you can see a ring enhancement just lateral to the lamina papyracea. Here you can see a focal bony defect, and this is a subperiosteal abscess. Okay. Important landmark for FAST surgery. It's good if we have a structured way of reporting things. There are a few things that we have to look for. We have to look for depth of olfactory fossa, whether there's patency of the OMU, and looking at whether or not there is congenital defect of the medial orbital wall, and whether or not there is presence of Onodi cells. There was a study done by this group of people who uses the closed mnemonic to avoid surgical complication, and the structures they look for would be the cribriform plate, looking at Keros classification, lamina papyracea, using coronal and axial image, looking for remote orbital fracture, Onodi cells, best seen in coronal, and sphenoid sinus pneumatization, especially looking for dehiscence of carotid canal. Okay, right. Mucocele. This is a benign entity, locally expand the PNS mass. It occurs most commonly in the frontal, followed by ethmoid, sphenoid, and MRI. and maxillary sinus. MRI has got a variable signal intensity. And here you can see that the bone is expanded and it has high content, hyperdense material within it. And you can see that it has caused polyposis within the maxillary sinus, the ethmoid sinus itself. Why is this not tumor? It's because you can see bony septations. The bony septations are still preserved. A tumor would usually eat and destroy bone. Polyposis wouldn't do that. You can still barely see some septations within the ethmoid sinus. Another example of sphenoid mucocele. This is uncommon. You can see expanded sphenoid sinus and it has extended into the posterior ethmoid itself and it has got high density material within. Okay, fungus, two types, non-invasive and invasive, right? Okay, now I'm showing you this is a non-invasive aspergillosis with fungal ball. Here you can see commonly occurs in the maxillary sinus. Usually it's solitary PNS involvement and you can see sclerosis of the sinus wall. And within it you can see calcification. Okay, and how would it look like on MR? It would usually be low T2 weighted image. Look at the axial image here. You can see the sphenoid sinus with calcific material within it. So this is aspergillosis with fungal ball. Invasive fungal, there will be two types. Imaging wise, sometimes it's difficult to differentiate the two. So how would we diagnose this? It will be according to your clinical presentation. If it's acute and patient is ill, then most likely it is acute invasive. If it's non-acute, then it will be chronic invasive fungal sinusitis. Here you can see how there is invasion of the mucosa and affecting the pterygoid plate. If you compare the pterygoid plate on T2 here on the left side or the right side compared to the left, it has lost the normal fatty signal of the pterygoid plate on the right side, so it has been involved. And as in this case, the signal intensity lebih kurang sama, but you can see that there is invasion through the lateral wall of the maxillary sinus into the adjacent soft tissue. Tumor, benign tumors. CT would be best, especially if you want to look for fibro-osseous lesion. Okay, now if you look at these two cases, what we see is expanded bone with ground glass appearance. So this is what ground glass appearance look like, and whenever we mention ground glass, it is fibrous dysplasia. And in fibrous dysplasia, sometimes you can see cystic lesion within, and that's the cystic component of the fibrous dysplasia. What about osteoma? Osteoma, again, it usually would be solid, and location can differentiate. It can have ground glassy appearance, but it is more dense than the ground glass appearance that one would see in fibrous dysplasia. Okay, tumor usually would involve the frontal sinus and the ethmoid sinus. It again non-specific presentation, and hence why usually there will be delay in diagnosis. So MRI is usually done to determine resectability, whether there is invasion, paraneural spread or things like that. And here you can see that there is destruction of the normal septae, in contrast with polyposis where you can still see septations within the soft tissue density. Enterochoanal polyp is a solitary sinonasal polyp. This is very classical, arise within the maxillary sinus, will cause widening of the maxillary ostium and extend into the nasopharynx. No bony destruction. This is a hallmark of enterochoanal polyp. What about inverted papilloma? Usually unilateral lesion. You find them in the lateral nasal wall, middle meatus, middle turbinate. Usually it will be associated with bone remodeling and resorption, and it can extend into the antrum. Again, non-specific symptom, but you need biopsy for diagnosis. Odontogenic lesion. Okay, if you see an opacified frontal sinus, opacified maxillary sinus, always determine where it is from. Whether or not it's purely coming from the maxillary sinus, or can it be due from the apex of the tooth, right? How do we tell? Can you see here that there is I panggil dia double wall tau. Bukanlah double wall, don't quote me lah. But if you see here, you can see another thin bone within the sinus. Nampak tak? You can see this as well. You can see tiburon. Ini lagi obvious lah because you see tooth within it, so you know it's odontogenic in origin. But in cases of apical cyst, this is what you see. You see another bone coming from the root of the tooth. Okay, that's how you differentiate whether or not where it is coming from. Another lesion, encephalocele, MRI will be able to tell you that. If you do CT, we won't be able to see it because what you see is just soft tissue density within the paranasal sinuses. But here you can see that there is a herniation of the brain into the nasal cavity. Yeah, and if you look at the the brain itself, the texture is not normal. The cortex is thickened, so this one probably would be something which is congenital. Okay, trauma. Here, we use plain radiograph mostly for trauma. It's a good screening. And what is most obvious here, you can see that there is an air fluid level in the left maxillary sinus. So you know that there is acute hematoma. But there is another abnormality that you can see here. Can you see any more abnormality other than the fluid level? The rule of plain radiograph is compare right and left. Just compare je right and left. Macam ni kita nampak kan, you know that there's air fluid level. Do you see anything extra?
Extra.
Come again?
Meter floor?
Yes, teardrop sign. That's a teardrop sign. Right? So there is fracture of the inferior orbital floor with herniation of the orbital content into the maxillary sinus. So this is a blowout fracture. Okay? So detailed knowledge of the paranasal sinus is very important. It's very important for you to localize and find what the anatomy of the adjoining structures are. Systemic analysis for the integrity of all these abnormality is very vital as well because you can get precise identification of pathology by using all this information that you have. And the role of CT, yeah, we can see soft tissue mass, sinusitis, very important, looking at the OMU, look for bone abnormality using CT, pre-op evaluation of FAS and calcified lesion. MRI, good for soft tissue detail, tumor spread in soft tissue, which CT cannot do, distinction of tumor from secretion, which CT cannot do. Perineural spread is the other thing that one would use looking for spread using MRI and intracranial invasion. Okay, that's all my lecture. I think I kena bagi you all quiz, tapi I tak ada Slido or I tak ada Kahoot. Tapi you all jerit je lah jawapan. I tak boleh lah nak tahu siapa yang dapat tinggi. Now, can you detect what variant is? Yes, this is halo cell. Senang kan? Right. What would your diagnosis be?
D. Allergy fungal sinusitis. Double.
You can see that there is hypodensity within it, and then you see some fluid retention within it. And here, can you see that all these
Sufficient
are this is not tumor. Whenever something you see which is dense, always think of a benign process. Yeah? Yes, this is allergic fungal sinusitis.
CT, hypodense, pain.
Oh, call their names. Your nak I call your name ke?
Oh my god.
Bisa.
Sama-sama Quiz 3. Ni dia orang sama-sama. Quiz 3. I ada berapa minit lagi? Ada 6 minit je lagi. Tak banyak, 8 je.
Dia cakap tak boleh hyper intense kan tadi cakap.
Anyone? Inverted papilloma. Wah, you all pandai lah. Dah boleh buat radiology dah terus. This is good. This is inverted papilloma. Here you can see T1 weighted image. You can see on T1 you can tell, you know, that these two are two different things, kan? This is secretion, which is hard on T1, and you can see some soft tissue within the nasal cavity, and it's predominantly located in the lateral nasal wall. And here you can see further ke belakang lagi, you see the the soft tissue density. You can see the fluid. There's a fluid here as well, and this is what it looks like. contrast. Okay, whenever it's high on T1, dah presently high on T1, it is difficult to comment on the enhancement pattern of that particular lesion because you can't tell whether ada enhancement ke tidak. Most of the time